Good morning. I just want to be sure that you don't hear a voice and don't see a person. You are not hallucinating. Just want to reassure that it's a problem of the podium and a petite presenter. Given the fact that we have such a limited time now, I'm just going to skip this slide because basically Alison and our colleague from Connecticut have spoke about what's happening in the country with respite care. I want to just focus a little bit more about New York, where we have New York State Medicaid redesign team, the MRT, and the MRT has put a lot of focus on high utilizers in New York State. I have to say that coming in live, we have been preoccupied or concerned about this whole issue of patients who are in the hospitals and are medically clear and cannot leave the hospital because there's no appropriate housing to go to. So we began conversations with Montefiore Hospital in the Bronx way back, I believe, 2009 or 2010, with the idea of developing a respite, a medical and social respite. I should say more a social than a medical respite, as you will see with the presentation. And Montefiore has really worked with us to develop the program from the very beginning, and later on, Bronx, Lebanon, who heard the effectiveness of this program, approached us to get beds from Community Life. And basically what we're going to do is talk a little bit about the environment here in New York and how do we do this. Today in New York City, hospitals do not get reimbursed once the patient has been medically clear. In other words, that rate of admission goes down. For example, in the Health and Hospital Corporation, the lower rate would be about $300 when the patient is medically clear and cannot go home or whatever, as opposed to perhaps $700. So there is a major loss for hospitals when a patient is medically clear and cannot leave the hospital. But in addition to that, we know that under the Affordable Care Act, hospitals are being financially penalized because they cannot discharge medically clear patients. And furthermore, the federal government are now penalizing hospitals for readmissions of patients within 30 days of discharge. So the notion is that hospitals are really, it's not only an issue of quality, but basically financially it's a challenge for hospitals in New York City. For my colleagues who are out of town, they may not know, but we all know here, that in the last 10 years we have seen a tremendous amount of closures of hospitals in New York City and New York State, and had to do a lot with financing of hospitals. So the purpose of our respite program is to provide a safe transitional housing for patients who are medically clear and do not require hospitalization but cannot be discharged to a stable home or a shelter. And client access medical care and other supportive services through our services in the respite care. The total number of beds that we have now is 10, but this was not what happened 3 years ago. We started again, hospitals want to know whether this is going to work or not, and we started with Montefiore with, I believe, 1 or 2 beds. And they saw then the effectiveness of the program, and they have continued to increase the number of beds that they are using. And the same thing happened with Bronx, Lebanon, that they started with a smaller number of beds, and they have increased the number of beds. I have to say that our respite, we don't have a clinic like I have heard my colleagues from Connecticut and others. We do have a mental health clinic in the Bronx, but what we have done is we have a facility, it's actually a shelter where we had unused space, like you did. And what we did was to convert some of that space to not rooms, but actually, there are beds within rooms that are shared with patients. And the whole notion that we had, quite frankly, was that many patients are in a hospital and you can go home with additional support, whether it is visiting nurse and other type of care that are going to be provided in your home. And I remember talking to the commissioner, the health commissioner, and say, do I need a license? And he said, you're crazy, Rosa. Basically what you're doing is almost as a patient who's going to go home, and what you're going to offer is an environment that is going to be protective of that patient. You are going to make the arrangements necessary for meals and everything else, but no, we don't want to give you or consider a license at all for such a program. So the idea here is, can we convert our program more or less like family to help this patient in this transition coming out of the hospital until we could get them housing and community life, like in the introduction, we have almost 1,500 units of housing. So the idea was that we could help these individuals in the transition from the hospital, and perhaps we could help them to get housing within our own network and also with other colleagues in New York City. Quite frankly, the assumption that Montefiore and ourselves had was that the majority were going to be homeless individuals, meaning living on the street or on a shelter. And I'll show you statistics that assumption was incorrectly. Actually, the majority of our patients were living with friends or family. So, whether that's the characteristic of New York City or not, I don't know, but there may be some things here that contribute to that phenomenon. The admission criteria was developed jointly in collaboration with the hospital. And basically, a little bit of what I heard before is the patient doesn't have a stable housing, needs an environment in which to prepare for the recover from medical procedures, be able, high ADL skills, be psychiatrically stable, and be sick enough not to need emergency services, and is not sick enough to be in a hospital, and have a condition that is identifiable at point of care of discharge. So in a way, it really resembles some of the criteria that I have read in the literature about other respite programs. We did say that the patient needed to was 21 years of age as minimum, and the patient must agree to rules and regulations of the program. And basically, and this is some of the lessons that we have learned from this program, which is my colleagues here who are you considering to do a respite program, you're going to have to think very carefully, how do you interact with the culture of a hospital? Here it was Montefiore approaching us, let's do this together. And we spent months after months, because after we had the beds, the social workers and discharge planners didn't want to use it, because they didn't understand it. They didn't understand housing. They didn't understand what we were offering. And I'm delighted, that the Corporation for Support Housing, who's actually here, has developed a training around housing and the needs and the different type of housing that we have in New York, to be able to help discharge planners and social workers in the hospital to see what the possibilities are. And we learned this very quickly, because one of the first patients that we had in this respite program was a gentleman actually who owned his home, but there have been family challenges, and when he was medically clear to go home, the family said, we don't want him. And basically, actually, there was a order of protection for him not to return to his own home. So when he came to the respite, we asked him, how could we help you? Do you want legal assistance? Can we challenge your family? So far and so on. And he said to us, can you help me to see whether I can go and live with families in Florida? And basically we did, of course, the appropriate research, and we were able to discharge that patient within 2 weeks of being in the respite. And when I thought about this, I said to myself, what was the social worker in discharge planning in the hospital that never really thought of asking this patient, where is your family? So, there's a lot of teaching that we need to do in thinking of the respite. And, the hospital, we spent time, we had developed brochures that we had given to the staff in the hospital. We meet with the staff, actually we do the assessment, at the hospital, and there had to be an agreement that between the hospital, the patient, that this is the right option for that patient. And then once we all agree that this is the best thing for this person, then the patient is referred to the respite. And we have a whole outline of what we require from the 2 hospitals to give us in terms of documentations for us to be able to appropriately do the plan for these patients. I'm going to try to skip this quickly. Somebody mentioned before how important it is the medication. And one of the requirements that we have from Bronx, Lebanon, and Montefiore is that they must provide the 30 days of medication for patients with chronic diseases and the antibiotics necessary. And we're very lucky that we have had a long history of working with a pharmacy in the community, and the medications are delivered to the patients. And we are not running a medical facility here. I said before, if you're home, somebody's going to get you from the pharmacy the medication, and you have the opportunity, to give that patient the medication there. So let me really skip this. This all had been discussed before, and we do pretty much what the rest of the country is doing. I just want to show you a little bit of who the clients are that we have served. We have served 52 individuals, and the majority of them are African Americans, and they're males. If you see the cohort between the ages of 45 to 62 constitute the majority of the patients that we have served. Medicaid, 75% do have Medicaid as a payer. Montefiore refer 37 patients, while Bronx, Lebanon have referred 15 patients. Now, it's interesting to look at the medical reason for referral was medical, primarily by Montefiore, while Bronx, Lebanon primarily referred patients for psychiatric respite. This is good. Where were they living before they were admitted to the hospitals? And we see 50% were living with families and friends, and that 25% were street homeless. Now, hospital readmissions rate. 56% of these patients had not been readmitted to hospitals, and the 23% have been readmitted. And it's interesting, which have been said in the literature, that within the first 30 days, in the early part of those 30 days, you tend to see an increase in the readmission, and that's what happened in this program too. We followed the pattern that we see in other respite programs in the nation. The readmissions have to do with the 30 days with medical reasons, and followed, but not to a great degree, by psychiatric reasons. And over the 30 days, there's a complete reverse there. After 30 days, you see psychiatric reasons for the readmissions, which is an interesting that we are looking at, quite frankly. Emergency visits, 81% of the patients in this rapid did not have a presentation in the emergency room. And if you think about what we do here in New York City, that is very good. very encouraging statistics. So in total, we have 10 patients who presented themselves in emergency rooms, and we see that within 30 days there were medical reasons, and then for the after 30 days is psychiatric. Now, what happened with these patients? Where did they go to live, right? Because that's what we are here about, is the discharging of these patients from the Respite program. Well, again, here we go. 31%, which is the majority of them, went to family and friends. And 23% were referred or living in support housing, and then the other large group is nursing home. Prior to hospital administration, the majority of the patients were living with friends and family, and I think 65% of the admission were for medical reasons, and it is interesting to know that, again, 31% after we discharged them from the respite went to live with family or friends. And I think I mentioned that before. I think that this program, at least the evaluation component that we have in the program, does show that it's effective and it's efficient. As we're moving here in New York City, we are going to have BHOs, right here. We have health homes. We have a lot of changes. And I will challenge all of us in this room just not to think about social and medical respite for, quote, hospitals. I mean, the managed care companies are going to have to be concerned with this issue of what happened to patients and the readmissions to them. So don't think only hospital, because the world of healthcare has changed dramatically and is changing dramatically. So I hope that gives you an idea of what we have been doing here in New York City. Thank you very much.